Good afternoon, everyone. My history is 69 years male with left thyroid lobe nodule. This is a low power view showing aspirated smear with a highly cellular clusters and few cells scattered singly, seen again as the hemorrhagic background. This is the hemorrhagic background, and these are clusters and sheets of cells. And in this few irregular nuclear membrane with the prominent nucleoli. Uh, Few inflammatory cells, mainly the neutrophils, are seen here. Multinucleated giant cells are seen. Aspirated smear under the Giemsa stain shows highly cellular pleomorphic tumor cells arranged in clusters and few scattered singly. Individual cells shows abundant granular cytoplasm, irregular nuclear membrane, high NC ratio, and prominent nucleoli. At focal areas, multinucleated giant cells seen. Background shows hemorrhage, inflammatory cells, mainly neutrophils, are seen. The diagnosis positive for malignancy, anaplastic carcinoma.
Okay. Good afternoon. Good presentation for Anna. I would have expecting more slides, microphotos. Anyway, so I will tell about this case S6, which is very interesting one, which we got in our hospital. So this patient was a 51-year-old female. She had dysphagia for 3 months, cough since 3 months, swelling in the neck, generalized weakness, and weight loss. On examination, 4 into 3 centimeter hard nodule in the right lobe of thyroid and moved with deglutition. Trachea was deviated to the right. Level 2 and 5 lymph nodes were present. On ultrasound examination, both lobes and isthmus were normal in size. Right lobe, there was heterogeneous lesion, which was 3.5 into 2.8 into 30 millimeters. No increased vascularity was seen. Cystic change calcification was present. Left lobe, there were two cystic areas. Isthmus was one cystic area was seen. Multiple bilateral enlarged lymph nodes were also seen. Thyroid profile was normal. Patient came to our hospital for further management. So this we received on ultrasound guided FNAC, showing this highly cellular tumor. Some areas were papilloid clusters, some were in sheets and singles. Some areas were showing repetitive microfollicles. Some areas were showing some papilloid structures. In some areas, the tumor cells were in non-cohesive sheets and singles. In high power, we could make out that the pleomorphism was marked anisonucleosis was seen, internuclear prominent nucleoli. Some areas of inclusions were also seen. This areas we had a doubt of whether we are discussing about this, and we saw a prominent nucleoli and a cribriform pattern of arrangement. The nucleoli was significantly prominent, which we had a doubt of what is this case we are looking at. Some areas inclusions, internuclear inclusions were there. As you already saw in the presentation of the postgraduate, we saw some giant cells, both mononuclear and multinucleated, and the tumor cells were quite bizarre. Some cells had vacuolated cytoplasm. Classical cribriform pattern you could see, and the prominent nucleoli is very much visible in this. Tumor giant cells, the prominent nucleoli. To summarize, the architecture was some areas repetitive microfollicles were there, papilloid arrangement were there, tridimensional clusters and cribriform pattern. Some were singles and non-cohesive pattern. Nucleus was enlarged, markedly pleomorphic, post-chromatin, prominent macronucleoli. There were some areas, occasional areas of pseudo-inclusions and tumor giant cells. So cytoplasm was moderate and vacuolated at places. So we gave a diagnosis of Bethesda category 6, which is malignant. So these were your differential diagnosis. Although we received good response for this case, and as Farhan also told, her differential was anaplastic. Naturally speaking, a lot of giant cells with severe pleomorphism, anaplastic carcinoma has to be ruled out in thyroid. Some of the other DDs with postgraduates gave was medullary carcinoma, and some gave undifferentiated thyroid carcinoma, some follicular earther cell carcinoma, and one or two DDs were metastatic deposits. Anyway, we worked up this case with the further evaluation. We got a CT done. So before going to this description, before going to the CT, we'll discuss your DDs and how we differentiate it. Okay, first DD, since some papilloid arrangement was there, so we saw whether that is correlating with this. Anyway, we had the its cellularity was very high. All the papilloid structures were there. Some follicles were there. Occasional pseudo-inclusions, but longitudinal grooves were absent. And the chromatin, the powdery chromatin was absent. Some of bodies was not there. And histiocytic giant cells were also not there. Then we had a doubt whether it is papillary carcinoma because the chromatin and nucleoli was not in favor of papillary carcinoma, and the papillae was not having a definite anatomical borders. So we ruled out papillary carcinoma in this. So then we came another DD was polydifferentiated carcinoma. Anyway, polydifferentiated carcinoma, the cellularity will be very very high and no patternless pattern will be there, which is some in our case there was some amount of pattern, some follicles, papilloid. So anyway, the poor differential carcinoma, don't so much nuclear primorphism will not be there. So that also we ruled out. Anyway, anaplastic carcinoma was a closed GD. We also thought of it. Anyway, the presence of nodules in this patient with usually a anaplastic will be very highly aggressive diffuse enlargement with fixity to and infiltration to adjacent soft tissues, the rapid growth and usually associated with hoarseness of voice, and the giant cells, so tumor giant cells will be significant more in number, will be always significantly more in number in anaplastic, which was not seen. Usually, anaplastic might not have much of a pattern. Usually, they're in singles and irregular clusters, but some amount of pattern were there. Sometimes anaplastic can have spindle-shaped cells with marked pleomorphism. Pseudo-onclusions also was in favor, but since the giant cells were not much, very occasionally seen, we also ruled out anaplastic carcinoma. So further investigation, we did a CT neck and thorax. We observed there was swelling, especially in the right. If you, the arrow, if you can see, there was a swelling in the right thyroid region, which was moving with degglutination, and there was a soft tissue extension in the right side, which you can appreciate in the right side. If I can point out in the pointer options. Okay. So this is the right thyroid swelling where you can see the lesion has soft tissue extension here in the right lower end in the neck region. So this is a high where you can see the thyroid lesion, which is hypoechoic, very infiltrating the nature of the lesion. So further bronchoscopy was done. There was an endobronchial mass in the right main bronchus arising from the right upper lobe. So the biopsy of the bronchial mass was done. You could see the tumor cells arranged in trabeculae and some acinoglandular pattern, and the nucleus was quite pleomorphic with extensive desmoplasia. This is another hyperview. You can see that tumor cells are infiltrating with marked pleomorphism. Cytoplasmic vacuoles were seen, which was significant, and some glandular pattern in the periphery. Yeah, classical glandular pattern, tumor cells infiltrating the stroma, some vacuoles in this cytoplasm. So tumor cells with inclusions, prominent nucleoli, areas of necrosis, some tumor giant cells. So we diagnosed it is a case of metastatic deposits from adenocarcinoma of the lung. Even in the biopsy, it was given as diagnosed as polydifferential adeno, whereas thyroid we gave metastatic deposits from the adenocarcinoma of the lung. So treatment advice was palliative radiotherapy followed by palliative chemo. Discharged patient was discharged against advice, and further loss for follow-up. So little bit discussion. Metastatic tumors of the thyroid are encountered in very rare cases, 0.1 to 0.3% of thyroid aspirates, 2.7 to 4% in surgical serious cases. In 25% to 50% thyroid metastasis is first manifestation of occult malignancy, which was in our case. In fact, before doing the CT, we had diagnosed metastasis with respect to the cytological findings. Anyway, the common primary which metastasized to the thyroid is lung, breast, melanoma, colon, and the kidney. So direct extension, pharynx, larynx, esophagus, mediastinum, and regional lymph nodes were all the same. We had seen some cases of esophageal malignancy infiltrating the thyroid. So some cancers with metastasis, which has a similarity with the primary thyroid malignancies, one thing is lung malignancies can have an anaplastic kind of a morphology, which can be mistaken for primary anaplastic of the thyroid. Melanoma can mimic as medullary thyroid carcinoma, and clear cell carcinoma of the kidney can mimic a follicular or an oncocytic neoplasm. So, what are the points which is considering metastasis? One is the pattern. Usually, the pattern of metastasis, either if it is adeno, you see a glandular pattern, papillary pattern, or a cribriform pattern. Prominent nucleoli is the main key features which helped us also to identify whether we are dealing with metastasis. So, macronucleoli with the cribriform pattern, glandular pattern, you should always rule out metastasis. The tumor giant cells is always a confusing pattern because giant cells, primary anaplastic, you see giant cells, tumor giant cells more significantly more with respect to the metastasis. So always you have to evaluate whether there is a malignancy in the other organs. Anyway, the PET scan or CT scan or clinical radiological examination is a very important to pick the primary. Thank you so much. I thank Department of Pathology for giving me an opportunity for presenting this. Thank you.
Good afternoon, everyone. I'm Dr. Deepthi, third year postgraduate from JSS Medical College, Mysore, and I'll be discussing about case S1 today. The history given was a 55-year-old female came with complaints of breast swelling. Uh, One slide was given for diagnosis. As we can see in the scanner view, we are able to appreciate a well circumscribed tumor with pushing borders. The tumor cells are seen arranged in syncytial pattern. The tumor cells are also seen arranged in sheaths and nests. Coming to the 40x view, individual cells have pleomorphic vesicular nuclei, prominent nucleoli, and moderate eosinophilic cytoplasm with indistinct cell borders. Mitosis, as seen, was 1 to 2 per high-power field, and a lot of atypical mitotic figures were also noted, as shown in this figure. And tumor infiltrating lymphocytes are seen within and around the tumor nest. To summarize the microscopic findings, sections show a tumor with pushing borders composed of cells arranged in syncytial sheaths and nests. Individual cells have pleomorphic vesicular nuclei, prominent nucleoli, and moderate eosinophilic cytoplasm with indistinct cell borders. There is prominent lymphocytic infiltration within and around the tumor nest. Mitosis was 1 to 2 per hyperfield, and there is no evidence of lymphovascular or perineural invasion seen in the section studied. So, according to the slide, the diagnosis would be invasive breast carcinoma, no special type, with medullary pattern, and it could be graded as grade 3 according to Bloom Richardson score. Thank you.
Dr. Deepthi, I appreciate you for highlighting all the major points almost correctly. Now let's go ahead what exactly happened with the case. So as the case given, it was 55-year-old female with a breast swelling. Clinically, she presented with 4 into 7 centimeter lump in the right breast in 6 months. But since 1 month, it was a fungating growth with the ulcer over the skin and nipple discharge. The mammogram showed large hypoechoic lesion in the lower inner quadrant of the right breast, infiltrating the overlying skin and the pectoralis muscle, with axillary lymphadenopathy consistent with a malignant lesion that is BIRAT 6, whereas the left breast was normal. What we received was a right mastectomy specimen, and on sectioning, we saw 7.5 into 6 into 5 centimeter gray white ulceroinfiltrative tumor with overlying skin showing ulceration and involvement of the nipple areola complex. On microscopy, as she said, we saw sheaths and nests of tumor cells, highly pleomorphic and highly cellular tumor. If we see the individual tumor, it is having polygonal appearance with pleomorphic cells, having vesicular nucleus, prominent nucleoli. Some had multiple prominent nucleoli as well, with abundant eosinophilic cytoplasm. The striking feature was tumor infiltrating lymphocytes. So, based on this microscopic feature, the differentials that we thought was the first one obviously was invasive breast carcinoma of no special type with medullary pattern. The second thing, can it be squamous cell carcinoma, metastasis from any other site, or is it a metaplastic carcinoma? So when I went through the differentials given by different pages, the main many of them told it was in IBC with medullary pattern. Yeah, in histopath it definitely looks like that. And few of them told it was DL BCL. We can consider that too in terms of histopath. So we went ahead with IHC. The first ER was negative, PR was negative. Whereas HER2 showed 3 plus score, which was positive. To prove that it was a breast primary and rule out metastatic SCC, we did GATA3, which was patchy positive. To prove the epithelial differentiation, cytokeratin fiber 6 was done, which was patchy positive. Next, we went ahead with P63, which was patchy positive. P16 was strikingly a strong positive. Next, K67 index was around 60 to 70%. So putting together the histopath and IHC markers, we can say that it is a metaplastic carcinoma, and it was of T4B stage as it was ulcerating the overlying skin. Currently, the patient is undergoing third cycle of chemotherapy and she's doing well. So why we gave it as a metaplastic carcinoma? Because we saw some atypical squamous cells, and what WHO says is we should have IBC with atypical squamous cells, spindle cells, either a mesenchymal or matrix producing differentiation. Along with that, immunohistochemistry evidence of epithelial differentiation with positive cytokeratin and or presence of positive P63. So little highlights on what is metaplastic carcinoma. It's a heterogeneous group of invasive breast carcinoma characterized by differentiation of neoplastic epithelium cells, squamous cells, and or mesenchymal looking elements. Clinically, usually it presents at the advanced stage. It consists of 0.2 to 1% of the invasive breast carcinoma. So histologically, it can be either monophasic or biphasic. To talk about the types, it can be epithelial only. Under this, we can have low grade and high grade adenosquamous carcinomas or pure squamous cell carcinoma, like what we saw in our case, or it can be pure monophasic sarcomatoid carcinoma or mixture of both, that is biphasic component. So prognosis wise, metaplastic carcinoma, most of the cases are triple negative cases, but as we saw in our case, it was HER2 positive metaplastic carcinoma, which has better prognosis than the triple negative metaplastic carcinoma cases. Thank you.
Thank you, Dr. Samiksha. The next case will be S2, done by Karwar Institute of Medical Sciences, Karwar, by Dr. Ajay Kumar. Over to you, Dr. Ajay.
This is Avijay Ajay Kumar, third year postgraduate, Karwar Institute of Medical Sciences, presenting S2 with a history of 26 years female, abdominal pain, and the number of slides given is 1. This is the slide. And in 4x, there is the H&D section from the ileum tissue shows columnar epithelium with numerous glands and lymphoid follicle. And there is discontinuity in the mucosa, like mucosal ulceration. And in submucosa, showing hypocellular areas, hyalinization, edema, and congested blood vessels. And in subserosa, this is in high power field, showing sheets of elongated spindle cells. Cells are with indistinct cell border and having pale cytoplasm and elongated nucleus. And in subserosa, there are congested and dilated blood vessels, which are microhemorrhages, and with spindle cells. And my overall microscopic description is section study shows interstitial epithelium with numerous glands and lymphoid follicles. Focal mucosal ulceration seen, few hypocellular areas seen consisting of spindle cells arranged in sheets extending from submucosa to subserosa. Cells are with indistinct cell border and having pale cytoplasm and elongated nucleus. No nuclear atypia seen. And submucosa shows stromal hyalinization, edema, and a congested blood vessel. And subserosa shows congested blood vessels. My differential diagnosis is fibromatosis and gastrointestinal stromal tumor. Uh, with demographics, the age group is 26 years and the females are more predominant. So, through demographics, I am thinking like fibromatosis. And the clinical symptoms, both of them are having abdominal pain. So and the location is here, it is looking like ileum, so small bowel dysentery. And in microscopy it is more correlating to fibromatosis. And IHC, if we do IHC beta catenin, it will be positive for fibromatosis if it is fibromatosis. Thank you.
Am I audible? Can I think everyone can see my screen?
Yes, yes.
Yes, Ajay, it was a good presentation. As you mentioned, even I will go through quickly about case. So, what we have given is a 26 years old female patient with abdominal pain. So this is the case details, expanded case details. Uh, it is a 26 years old female patient presented with abdominal pain and left flank pain since 3 months. And uh, when we received the CT report, it showed that a well-defined heterogeneously enhancing large lesion measuring around 7.2 into 7.1 into 7.1 centimeter with necrotic areas showing peripheral capsular enhancement with central few specks of calcification. And this lesion is also abutting the tail of pancreas and splenic hilum, as well as greater curvature of stomach and colon. So it's a huge lesion present in the retroperitoneum and in the peritoneum as well. So the possibilities of um, this lesion to be SPEN or GIST was given by a radiologist in the CECT. So when we received the specimen, um, according to gross examination, the specimen showed a gray white irregular tumor arising from the body and tail of pancreas. It was measuring around 10 into 9 into 7 centimeter, extending into splenic hilum and extending as well as extending into the serosal surface of colon. So the sections which we gave for slide seminar is the colon section. Here, I think, one second. You can see the colon epithelium and as you mentioned about the discontinuous, it may be due to, I think, pressure effect maybe. Hmm? The tumor is fairly circumscribed. It's not well circumscribed. As you can see about same thing, the arrangement of cells, the cells are arranged in sheets and long fascicles as well. Here only you can see fascicles. And in the next slide, see, this is a 10x slide, and one fascicles can it's arranged in a span of 10x field. So we 10x field, and the cells are bland, and there is not much of pleomorphism is there. And here blood vessels are thin walled, which you forgot to mention. You mentioned about congested blood vessels, but one thing you have to notice is that all the blood vessels are thin walls, and here we can see even staghorn shaped vessels as well. And here, see, this is the muscularis propria, and the lesion is almost infiltrating the submucosa as well. It's infiltrating the submucosa, and at the edges of the lesion, we can see lymphoid aggregates at the advancing edges. So microscopic findings, as we saw, multiple sections. They show tumor component comprising of spindle cells in diffuse sheets, fascicles, and vague even storiform patterns. We saw few storiform patterns, and the individual cells show bland morphology, vesicular plump nuclei, indistinct nucleoli, and eosinophilic cytoplasm. Mitotic figures were very rare. I was not able to see anything. And dense neutrophilic infiltrations are noted at the advancing edges. So differential diagnosis according to just morphology and histomorphology is it's a spindle cell neoplasm favoring desmoid fibromatosis and GIST. And as you mentioned about fibromatosis, and you gave a nice differentiating features between the both. So I won't go into much about into differentiating these two. So responses in the portal is out of 26, 17 were of GIST, because I think maybe because of the site of the lesion. But if you hear the size of the lesion and age and all, if you compare it, I think most of the responses should have been fibromatosis. And few people gave some other vague diagnosis, something like parasitic lesions, like strongyloides stercoralis and amoebiasis. I don't know who they felt that. And coming to IHC, so later we went to IHC to distinguish between these two. But our main diagnosis was fibromatosis. So according to IHC, as you can see, dog 1 and CD117 was almost negative. Both were negative. We can see CD117 sometimes in the desmoid fibromatosis, but here both were negative. Eccentric because even at the beginning we felt it might be even neural also. Hmm? But beta catenin is the turning point. It is positive. Positive means a little bit patchy, but it was nicely positive. On key 67 was just 2%. So here you can see the slides. Vimentin diffusely positive, desmin also diffusely positive. We also did the SMA. SMA and MSA can be positive in desmoid fibromatosis. Majority of the cases it will be positive, but for us it was negative. And beta catenin, it's a nuclear staining. It's moderate to strong. Few cells were strong, few were moderate, and few places it was negative. But we concluded that it was suggestive of fibroblastic and myofibroblastic neoplasm. Mainly, it is desmoid fibromatosis. See, whenever you give diagnosis of fibromatosis, just fibromatosis, I think you shouldn't stop with just fibromatosis. If the lesions are deep lesions, something like retroperitoneal or in the deep muscle and all, you can call it as desmoid fibromatosis. And I think that concludes it. Thank you for giving an opportunity to present here. Any questions?
Good afternoon. I'm Dr. Susanna, a third year postgraduate student from Basveshwara Medical College and Hospital. And the case we'll be discussing today is SP, and the history given to me is 35-year-old male and a colonic biopsy and a skin nodule. Full mount view of this colonic biopsy. H&E stained section shows multiple fragments of colonic mucosa. Mucosal surface erosion made out with diffuse expansion of lamina propria by foamy histiocytes. Mild crypt distortion with lymphoplasmocytic infiltrate noted, no evidence of dysplasia. And another micrograph showing sheets of foamy histiocytes. At higher magnification, few foamy histiocytes are packed with small, round to oval, uniform structures with peripheral clear halo, morphologically consistent with histoplasma capsulatum, and sheets of foamy histiocytes with intraplasmic, uniform, small, round, oval structure. Another peel showing histoplasma capsulatum. And here we see a narrow-based yeast budding noted. The second slide given was a biopsy of a skin nodule, two skin punch biopsies, including subcutaneous, a whole mouth view. Here we see epidermis showing acanthosis and loss of rete ridges. Reticular dermis and subcutaneous fat show dense inflammatory cell infiltrate. Granulomatous inflammation around blood vessels, nerve bundles, and adnexal structures, along with rich histiocyte infiltrate seen. Another micrograph showing another field of granulomas. Subcutaneous fat shows necrosis, granulomas, neutrophilic infiltrate, and histiocytes. Histiocytes have intracellular uniform round, small round organisms with peripherally clear halo. So the diagnosis is disseminated histoplasmosis involving colon and skin. The further investigations you could do for histoplasmosis is PAS, GMS, and GIMSA stain, antigen antibody detection or molecule assays, culture studies, bone marrow study, blood counts, LFT, RFT, urine analysis, inflammatory markers, radiological investigations like CT, brain, chest, and abdomen to rule out involvement of other organ systems, HIV status, immune status, and TB screening. We need to know the immune status of the individual transplant recipient, malignancy or if he's on any steroid therapy. Other pathogens considered for differential diagnosis for histoplasmosis, my first differential would be leishmaniasis. Amastigots have kinetoplast and do not stain with fungal special stain, but are highlighted by GIMSA stain. And they are both intracellular and extracellular. And there'll be absence of Marquez sign, increased presence of plasma cell in the background. Cryptococcus neoformans. There's they are pleomorphic yeast and they are larger in size, 5 to 10 micron in diameter, and candidial spores, which lacks halo.
That was a great presentation, Dr. Susanna. And you have made my job very easy because you have rightly hit the diagnosis. I'm even happy when you have zoomed and shown the narrow based spores in the pictures. So I'll just tell you a little extra information about this case. So it was a 34-year-old male with abdominal pain and loose stools of 3 days duration. He didn't have bleeding per rectum and there was no history of fever also. However, around 10 to 12 years back, he was a known case of IgA nephropathy and he had received a renal transplant and he was on immunosuppressive therapy since then. Okay. And the investigation wise, he was anemic and occult blood was positive, okay, in stool. Ultrasound abdomen showed bowel wall thickening, long segmented bowel wall thickening. So they told it may be an inflammatory etiology which is causing the thickening of the bowel. So they went ahead with the colonoscopy. As you can see, there were a lot of ulcers, some discrete and some confluent ulcers. And scopy wise, they thought it may be a Crohn's disease. So moving on to the microscopy, you can see this is the colonic mucosa, which is lost the epithelium. There is ulceration covered by exudate. Lamina propria showing mild increase in the lymphoplasma cells. There's cryptapsis here. What else we saw is the lamina propria expanded by these foamy histiocytes. So why it is foamy, we'll see more pictures. So you can see a lot of organisms within these histiocytes. Most of them are intracellular. They, they were even seen where there is granulation tissue. You can see these foamy cells. And to see these cells, what is there within these histiocytes are these spores. Okay, so round to oval spores, quite uniform with the halo around it. Okay. So we did a GMS stain and pass stain to confirm whether they were really fungal spores. So it was beautifully positive, as you can see, all those positive within the histiocytes. The pass was also positive. So apart from that, we also saw what you missed is within the scripts. Okay, so the cells within these crypts, the epithelial cells were a little enlarged. Nucleus was enlarged, appearing like an outline because of the inclusions within the nucleus, eosinophilic inclusions within the nucleus. There were also some endothelial cells showing smudging of the chromatin. Okay, so we were thinking of there may be a CMV also in this tissue. So we did an IHC for it, and it was beautifully positive. Here you can see the IHC positivity. So moving on to that fungal spores, which was positive for PAS and GMS, you have discussed the rest of the DDs. So what was left is pneumocystis, which also will be GMS and PAS positive, but most of it will be extracellular in location. Ours was predominantly intracellular within the histiocytes. Blastomyces, instead of narrow-based budding, they have a broad-based budding. That is a difference. So it was a histoplasma capsulatum because they had this round to oval narrow-based budding yeast, which was predominantly intracellular within the histiocytes and few were extracellular. The protoplasm of the spores they retract during fixation, which creates that halo as well as pseudo capsule. There will be GMS and PAS positive cell wall in this. So the diagnosis of the colon was an infectious colitis with co-infection with histoplasma and CMV. So during the follow-up, he came with the skin lesion. So there were tender erythematous plaques seen on the thighs and calf. So biopsy was also done. And this you have already told. So there's skin with epidermis, dermis, papillary, reticular, and subcutaneous tissue. And predominantly in the reticular and the subcutaneous tissue, there is some changes. You can see a lot of cells that gives a bluish appearance. So to focus more and to zoom, you can see this some granulomas here. You can see the epithelioid cells and cuffed by the lymphocytes here around the vessels, around surrounding the nerve bundles. So in the subcutaneous fat also, there's a lot of inflammation, as you can see. So when we zoom it, there's areas of fat necrosis. So along with that, we could see this again, the spores, what we saw in the colon, okay, with the halo here. Okay, the response was due to this fungal spores. So you can see these fungal spores And the granulomatous suppurative response, again, there's a lot of neutrophils, granulomas, suppurative granulomas here. You can see again the spores here, and surrounding that, there's a response, granulomatous response. Some more, again, spores surrounded by epithelioid cell aggregates. Okay. Pus was also positive in this case. So the diagnosis of the skin is disseminated histoplasmosis involving the skin of the thigh. So uh, Histoplasma capsulatum, it's a dimorphic fungus, so it appears as a mold outside the body, and as it is inhaled and goes to the lung within the alveolar macrophages, it forms yeast forms. And usually, in an immunocompetent individuals, they are asymptomatic. Whenever the immunity goes down, it spreads through the blood into different organs, and that time we call it as disseminated histoplasmosis. Incidence is more common in immunocompromised host, and GI tract up to 90% cases is involved, and skin is little rare, that's why this case is given. And regarding CMV, we know that that is also, it's a viral infection. They also remain as latent when in a immunocompetent host, and they're asymptomatic. Whenever the immunity goes down, there will be reactivation of this latent infection. Now, moving on to co-infection, they come with abdominal symptoms of pain, loose stools, fever, and bleeding per rectum. Scopy just mimics IBD, so that's why in our case also they told it VB or Crohn's disease. The microscopy I've already discussed. This budding spores, narrow base, you've already told it elaborately. CMV inclusions, they can be seen in epithelial cells, endothelial cells, and as intranuclear eosinophilic inclusions and purplish inclusions in the cytoplasm, giving a owl-like appearance. Diagnosis also you have touched upon, and histopathology and culture remains the gold standard for histoplasma, and IHC and PCR for CMV. Treatment, the treated disseminated ones are treated with liposomal amphotericin B and oral itraconazole, and antiviral drugs. The intravenous ganciclovir is used for CMV colitis. Prognosis is dismal for co-infection, and till date, 6 cases have been reported: 4 in AIDS patient, and 1 in rheumatoid arthritis with steroids, and 1 case only in a patient who has had a renal transplant. So ours was a second in literature who is having this co-infection. Thank you.
Amen. 30 seconds done. Okay, so if we see, the first image shows a blast with plenty of ore rods. The second image is MPO stain showing strong positivity. And the third image is actually the retinoic acid, which is used in treatment of this condition. It is APML. The next one, you have 30 seconds. You can put your answers in the chat box. So yes, this is a case of multiple myeloma. As the CRAP shows, it describes the CRAP criteria, where we have to see the calcium levels, we have to see the renal involvement, we have to see for anemia and any bone lytic lesions. The X-ray of the skull shows plenty of lytic lesions, and what is shown over here is Benz-Jones proteins. Can you identify the scientist and his contribution if possible? Mr. Pat. Anybody? Make any guesses, it's fine. He has won the Nobel Prize. No? He was known to discover an organism. He ingested the organism himself to prove his theory. So this is John Robin Warren. He was known for his discovery of Helicobacter pylori and gastritis. Yes, we can see it now. You can start.
Okay, ma'am. So the history that was given was 30-year-old male, fever with lymphadenopathy. So microscopic findings. So this is under low power.
So the given slide under H&E stain shows a single linear bone marrow tissue section showing 14 to 15 intertrabecular spaces. And the cellularity appeared mildly hypocellular for each. On high power, trilineage hematopoiesis was noted. There was erythroid series, myeloid series, megakaryocytes seen. Mild suppression of erythroid and myeloid series was seen. Megakaryocytes were adequate. Few hypolobated forms were seen. Noted patchy to diffuse infiltrate of large atypical cells with high NC ratio, convoluted to irregular nucleus with open chromatin conspicuous to prominent nucleoli and moderate cytoplasm. Also seen were mononuclear cells, which were these large cells with round to oval nucleus with a prominent single nucleolus and moderate cytoplasm. So these were the mononuclear cells that were seen. And the background showed plasma cells and occasional scattered neutrophils and few small mature lymphocytes. I also saw one occasional binucleate cell. Then there were these vague epithelioid cell collections, which could be a granuloma. So to summarize, the bone marrow trephine biopsy shows 14 to 15 intertrabecular spaces satisfactory for evaluation, mildly hypocellular for each. Erythropoiesis, granulopoiesis was reduced. Megakaryocytes were adequate with occasional hyperlobated forms. Patchy to diffuse infiltrates of neoplastic cells noted, which are large atypical cells with high NC ratio, irregular nucleus, and prominent, conspicuous to prominent nucleoli. The background showed plasma cells, lymphocytes, and occasional scattered neutrophils. Mononuclear Hodgkin cells seen, and a few binucleate cells were seen, and occasional vague granuloma was seen. Impression features are suggestive of bone marrow infiltration by hematolymphoid malignancy. So, considering the clinical picture and the histomorphological findings, it could be most likely due to a lymphoma spillover. So, these were my differential diagnosis for this. So, looking at the histology, the characteristic mononuclear cells that we saw, and also the polymorphous inflammatory infiltrate in the background, and a diffuse infiltration pattern, along with the clinical features, favors diagnosis of Hodgkin lymphoma. My other differential diagnosis were mantle cell lymphoma, follicular lymphoma, lymphoplasmacytic lymphoma, and diffuse large B-cell lymphoma. But we need to do further immunohistochemistry to rule out or confirm the diagnosis. So we can start off with CD45, whether it's positive, then pointing towards a non-Hodgkin lymphoma, or if it is negative, then towards a Hodgkin picture. Then we can do a Hodgkin panel like CD30, CD15, and pan B cell markers like CD20, CD79A, and PAX5. And then other markers like germinal center markers, CD10, BCL6, as well as for lymphoplasmacytic lymphoma, we can do a plasma cell marker, CD138. So the most of the features are pointing towards a provisional diagnosis of an infiltration by Hodgkin lymphoma.
Thank you, Dr. Atulya. You had almost come to a diagnosis. I think if you had an IHC help, you would have come to the diagnosis. So I will tell you how we went about the case. Initially, we got a peripheral smear of the patient with history of fever, headache, and generalized lymphadenopathy. There was no hepatosplenomegaly, and patient was a known case of type 2 diabetes. So the CBC was sent to us initially with the hemoglobin of 15.8 gram, total leukocyte count of 17,390 with the predominance of neutrophils. The percentage of neutrophils was 95% and platelet count was also normal. Next, to the peripheral smear, we were examining the peripheral smear and we noted initially looking at the count and the high WBC count with the predominance of neutrophils. We were thinking in terms of infective condition, but then these cells caught my eye So you can see here a small percentage of cells. There were about 3% atypical cells in the peripheral smear with a convoluted nucleus and cytoplasm containing vacuoles. So these cells look little obvious. Initially, we thought whether it was toxic granules, but then these toxic vacuoles. But these vacuoles were all uniform in size, and which gave a suspicion to us. And then when we asked bone marrow examination, next they proceeded with the bone marrow examination, and there was generalized lymphadenopathy. So simultaneously, they carried out a true cut biopsy of the lymph node and the bone marrow aspiration. So bone marrow aspiration showed sheets of large pleomorphic lymphoid cells with high NC ratio, convoluted nuclei, clumped chromatin. And here also you can see the cytoplasm, abundant cytoplasm or moderately abundant cytoplasm with vacuolated, which was vacuolated. The same vacuolated cytoplasm which was seen in the peripheral smear was also seen over here. Occasional atypical plasma cells and some neutrophils and lymphocytes were also there in the aspiration smear. So in a higher power view, so you can see the vacuoles, plenty of vacuoles in the cytoplasm. With the basophilic, most of the cytoplasm was basophilic, moderate amount vacuolated, and in between you could see a large wreath-like arrangement, multinucleated cells also. The bone marrow examination showed partial effacement and focal effacement of architecture with infiltration of the neoplastic cells. A higher power view showed the pleomorphic infiltration by pleomorphic lymphoid cells with a polymorphous background. So it could be easily confused with Hodgkin's because of the polymorphous background containing lymphocytes, plasma cells, neutrophils, and also the large cells in between with wreath-like arrangement of the multiple nuclei. So one of the important diagnoses we did consider was Hodgkin's. So the bone marrow biopsy, again a higher power view showing the vacuolated cytoplasm, the lobated nucleus, and multiple nuclei. So next we simultaneously we got the lymph node also. Actually the lymph node slides was one day earlier to the biopsy because biopsy had to undergo a decal. So the lymph node showed effaced lymph node architecture with small to medium sized anaplastic cells and the infiltration of interfollicular T zones. A higher power view of the lymph node biopsy showed large-sized cells having pale eosinophilic vacuolated cytoplasm, pleomorphic vesicular convoluted nucleus with multiple nucleoli, and background was polymorphous with neutrophils, plasma cells, lymphocytes. So at this stage, our differential diagnosis was anaplastic lymphoma, Hodgkin's lymphoma, diffuse large B-cell lymphoma, and pleomorphic carcinoma. So next we went ahead with the IHC. IHC, first we wanted to rule out metastasis because especially in the lymph node as well as in the bone marrow, there was clustering of cells. Those abnormal cells were seen in clusters. So we thought whether it was a metastasis. We did a pan-cytokeratin which was found to be negative. So with that we ruled out metastasis. Next we went to the markers of lymphocytes. So CD3 showed a diffuse positivity. So this showed that this is a T-cell lymphoma. CD20 showed reactive B lymphocytes here and there, scattered reactive B lymphocytes were highlighted. CD15 occasional scattered cells were positive. CD30 diffuse and strong positive. We did an ALK positive because we thought of anaplastic lymphoma, and ALK showed diffuse cytoplasmic positivity with the membrane accentuation. K67 was 90% at hotspots. So summary of our IHC results: pan-cytokeratin was negative, CD3 was positive, CD20 reactive lymphocyte showed positivity, CD15 scattered positive, CD30 was diffuse and strong positive, ALK was positive, and K67 was 90% at hotspots. So our final diagnosis was anaplastic T-cell lymphoma, ALK positive with infiltration of the bone marrow. So anaplastic T-cell lymphoma is one of the lymphomas seen in young adults, seen in children and young adults. It is also, a small percentage is also seen in adults, about 3%, but it forms about 10 to 30% of lymphoma seen in children and young adults, especially in the first 3 decades. It has got a relatively good prognosis, and it is found to be curable. So that's it. Thank you.
Thank you, ma'am. The next presenter is case S4.
Are you able to see me?
Yes,
I am
yes,
visible.
yes. Make it full screen.
I am Dr. Preetika Sharma.
Make it full screen.
I am Dr. Preetika Sharma, first
Yes.
year postgraduate from EMA Medical College, Gulbarga. History given to me was 57-year-old female, FNAC of left breast lump. So it's a 4x view showing smear which is highly cellular with sheets and clusters of cell against a mucinous background and foamy vacuolated material. In this view also we can see there is a mucinous background. In 20x view we can see there is clusters and sheets of highly pleomorphic cells and they are quite cohesive. In another view, we can see that the smear is cellular and tissue fragments are embedded in mucinous background. In this, we can see the self morphology quite evidently. So we are able to see that cells show pleomorphism. We can see enlarged or round to oval nuclei with coarse chromatin, irregular nuclear membrane, and prominent nucleoli. Few cells show squamous differentiation, and we can see few malignant epithelial cells which are floating in the mucinous pool. Now here we can see the cytology better. We can see the cell is showing prominent nucleoli. In this 40x view, we can see few cells which are enlarged, have irregular nuclear membrane, prominent nucleoli, and moderate cytoplasm in mucinous background. This is a 40x view. So to summarize, the arrangement is cohesive sheets, few cells show intermediate like form morphology. Squamous differentiation can also be seen. Few isolated malignant cells with loss of cohesion are also seen. Cells which are pleomorphic, round to oval, coarse chromatin, irregular nuclear membrane, prominent nucleoli, and moderate cytoplasm. And in the background, we can appreciate mucinous, abundant mucin. Coming to diagnosis. So according to Yokohama classification, we have the category C5, positive for malignancy with mucinous differentiation. And my differential diagnoses are mucinous carcinoma high grade, and second one is mucoepidermoid carcinoma. Coming to summary, so we can see there is a highly cellular smear with cell pattern which is cohesive with some singly scattered malignant cells, cytoplasm which is abundant, nuclei which is enlarged, pleomorphic, irregular nuclear membrane, prominent nucleoli, few cells showing squamous differentiation, and few intermediate-like cells are also noted. And in background, we can see abundant mucin and lipid droplets. Coming to differential diagnosis, so we can see mucinous carcinoma. To confirm our microscopic picture, we have to do some IHC. So if we are suspecting mucinous carcinoma, GCDFP15 will be positive and MUC2 will be positive. Coming to mucoepidermoid carcinoma, we see a mixture of both mucus, epidermoid, and intermediate cells. And positive IHC will be P63, MUC1, and MUC5AC. Thank you.
Yeah, that was a nice presentation, Pritika. So, coming to the history of the case, she's a 57-year-old female with a complaint of a lump in the left breast. Okay, radiological findings were showing a well-circumscribed hypoechoic mass in the central quadrant, which measured about 4 into 2 into 2 centimeter, and FNSC was advised. The guided FNSC was done on the aspiration we received
the hemorrhagic mucinous material. Hemorrhagic mucinous material in this picture, in the scanner view, you can see a mucin, and in between you can see some cells which are giving a chicken wire like pattern, and you can see some the cells which are floating within the mucin. This is the highly cellular area which showed tumor cells arranged you can see in the wake papillary pattern, in loose discohesive sheets, and in singles you can see some amount of mucin and hemorrhage in the background. So higher power of the same, you can see some vague papillary pattern, discohesive sheets, and as you mentioned, you can see the pleomorphic tumor cells. Here you can see the vague papillary pattern, and you can see the pleomorphic tumor cells having showing a high NC ratio, and the coarse chromatin, prominent nucleoli. Some cells shows abundant vacuolated cytoplasm, which is pushing the nucleus to the periphery. Okay, you can see some other cells too. See, this is the closer view of the same. You can see the cell having a pleomorphic nucleus, which is pushing the nucleus to the periphery, and vacuolated cytoplasm. The same type of cells you can see. So the FNSC showed the blood mixed mucin in the background, having tumor cells which are arranged in discohesive sheets, clusters, papillae, and in singles, which displayed marked pleomorphism like high NC ratio, coarse chromatin, vacuolated cytoplasm with prominent nucleoli, and background showed some amount of large amount of mucin and hemorrhage. Okay, we gave it as the category 5 ISA Yokohama reporting system of reporting the breast cytology, and we considered it as a mucinous neoplasm. We considered the differentials of mucinous carcinoma, mucinous cystadenocarcinoma, mucoepidermoid carcinoma, and metastatic mucinous carcinoma, and we advised for a histopathological and IHC for the confirmation of diagnosis. So on histopathology, we received the MRM specimen of a left breast. Cut section showed a gray white irregular tumor measuring 4.5 into 2.5 into 2 centimeters, showing multiple cystic spaces filled with a mucinous and gelatinous material. So this is the higher power. This is a scanner view of the tumor. You can see the tumor cells which are floating within the mucin. Okay, and you can see the fibrous strands in between. Again, higher power of the same, you can see the tumor cells which are floating within the mucin with the fibrous strands in between. This is the closer view of the same, shows the tumor cells having large round nucleus and the eosinophilic cytoplasm, coarse chromatin. This higher power of the same. So we advise for IHC. IHC showed positivity for ER, PR, and the GATA. HUD2 mu was negative. So we considered it as a mucinous carcinoma of left breast, which is which showed more than 90% of the mucin. So we considered it as the pure mucinous carcinoma with capilla type A, where we can see the tumor cells which are arranged in small clusters, and the capilla type B will be having sheets of tumor cells which will be having neuroendocrine like features. So we considered it as the pure mucinous carcinoma capilla type A.
Is it visible, ma'am?
Yes, it's visible.
Yes, ma'am.
Make it full screen.
I'm Dr. Renuka,
Yeah.
third year postgraduate from Karnataka Medical College and Research Institute, Hubli. I will be presenting the discussion case number 1. History given was 3-year-old child, posterior cervical swelling. This is the scanner view. This is the scanner view showing aponeurotic fascia and the skeletal muscle fibers. This is the scanner view showing tumor tissue with the interspersed skeletal muscle fibers. This is also the same tumor tissue with the interspersed skeletal muscle fibers is seen. This is the low power view showing tumor cells arranged in the fascicles. In this, the tumor cells are showing abundant vacuolated to amphiphilic cytoplasm, and the nucleus are rounded to ovoid to spindled. This is the picture showing mitotic figures. This is the tumor giant cell. This is the high power view showing tumor cells having abundant vacuolated to amphiphilic cytoplasm, and the nucleus is moderately large with round to oval to spindle shaped and vesicular nucleus with irregularly clumped chromatin and inconspicuous nucleoli. Microscopy section studied shows tumor tissue with interspersed skeletal muscle fibers and fascia. These tumor cells are moderately large with abundant vacuolated to amphiphilic cytoplasm, and nucleus is large, round to oval, spindled, and it is vesicular with irregularly clumped chromatin and indistinct nucleoli. At places, tumor cells are seen arranged in fascicles. Section also shows tumor giant cells, and good number of mitotic figures are seen. Diagnosis is feature suggestive of clear cell sarcoma. Some of the differentials can be considered are fibrosarcoma and epithelioid sarcoma. The age group in the clear cell sarcoma in the series conducted was 7 to 83 years, and it mainly affects between 20 and 40 years. In infantile fibrosarcoma, it occurs in newborns, infants, and children. In epithelioid sarcoma, it usually occurs in adolescents and young adults. Site of involvement in clear cell sarcoma is mostly extremities, and head and neck region and trunk are rarely involved. In fibrosarcoma, commonly involved is extremities, and next most common is trunk and head and neck region. In epithelioid sarcoma, it is rare in trunk and head and neck region. Cellular arrangement in clear cell sarcoma is nests or fascicles. In fibrosarcoma, it is arranged in fascicles, imparting the herringbone appearance. And in epithelioid sarcoma, it is tumor cells are mainly arranged in nodular pattern, with the tendency to undergo central degeneration and necrosis. And the cell type in clear cell sarcoma is rounded or fusiform cells, whereas in fibrosarcoma, it is spindle-shaped cells. In epithelioid sarcoma, it is of ovoid or polygonal to plump spindle shaped cells, whereas cytoplasm in clear cell sarcoma is of clear due to intracellular collagen or pale staining cytoplasm. In fibrosarcoma, cytoplasm is scant to moderate eosinophilic cytoplasm, whereas in epithelioid sarcoma, it is deeply eosinophilic cytoplasm and it is not clear. Nuclei in clear cell sarcoma are round to ovoid vesicular nuclei with prominent nucleoli, and it is associated with multinucleated giant cells. Whereas in fibrosarcoma, nuclei are spindle shaped and hyperchromatic nuclei. In epithelioid sarcoma, nuclei are vesicular and shows prominent nucleoli. In clear cell sarcoma, stroma shows fibrocollagenous tissue. In fibrosarcoma, it is of two types, desmoplastic type and medullary type. In medullary type, tumors with minimal amounts of collagen shows small, rounded, immature appearing cells with focal evidence of fibroblastic differentiation. In epithelioid sarcoma, dense hyalinized stroma is seen. Mitosis in clear cell sarcoma, it is less than 2 or 3 per 10 high power field, and in fibrosarcoma mitotically it is active, and epithelioid sarcoma mitotic figures are frequent. In clear cell sarcoma, melanin pigment is often seen, whereas in fibrosarcoma and epithelioid sarcoma it is absent. IHC in clear cell sarcoma, S100, HMB45, Melan A, Melcam, microphthalmia transcription factor is positive. Neuron specific enolase, LEU7 and LN3 have also been noted in these lesions. In fibrosarcoma, MSA, SMA, H called as is positive. Whereas in epithelioid sarcoma, low molecular weight and high molecular weight keratins, EMA, vimentin, CD34 is positive, whereas S100 is negative. My diagnosis is clear cell sarcoma. Thank you.
Thank you, Dr. Renuka. The discussion will be taken over by Dr. Kishan sir.
Okay, thank you, Renuka. It is a quite comprehensive description of the slide, whatever we are given. So, if you add some more point, I think you could have been made the diagnosis. So, this 3-year-old female with presented with the posterior auricular swelling. Clinically, it was diagnosed as epidermoid cyst and a lymph node. And any personal history or any other history, childhood history, developmental history was not contributory. When any obvious swelling is there, first diagnostic tool will be FNACs. And whenever you are dealing with some lymph node like mass, obviously we need to ask for some other investigation. So in this case, the PET-CT, it showed there is some increased uptake of FTG at tonsil, posterior auricular, subcarinal lymph node. and hematology and biochemical investigations were unremarkable. We did the FNAC for this case, thinking that can it be lymph node. Renuka, can you come into the picture? Can you tell about this case? What do you feel now, Renuka?
Yes, sir.
Can you tell what can be this? What is the morphology according to you? Okay, it is a spindle as well as you described in this cell. There are round cells, both.
Sir.
So spindly, there'll be crushing cells, there'll be spindly cells as well as round cells. Do you feel it is a malignant now, according to FNAC?
Malignant, sir.
Malignant. Okay. So thinking that it is a lymph node swelling, we also thought in the same way. As per this category 5, Sydney system of reporting, we thought it is a metastatic deposit from malignant small round cell tumor. Now, they went ahead with the excision which you are described properly. So this is the wet mount. Nowhere we could make out any lymph node tissue. It is a purely looks like a soft tissue swelling. And as you described, it was more of there is some nodule, multiple nodule, looks like a conglomerate nodule of some mass. And you could make out there are spindle cells, very quite cellular, very busy cell, very busy tumor. With the spindly cells, they are arranged in sheets or in, as you described, could be it is a fascicles or there will be some nodules. It is in the form of nodule. Uh, Also, there are some myxoid areas. Yes, it is seen. Myxoid areas is also seen. Predominantly, it is a spindly cell morphology with the compactly arranged cells in the nodules and within the myxoid areas. Uh, as it is invading the muscle, you said it is within the muscle. It is a muscle. It is looks like the same tumor cells, which is looks like invading the muscle. Definitely, it is indicating it is a highly infiltrative tumor. We are not looks like it is not a benign. You are looking at it is invading the adjacent muscle. You are dealing with some malignant lesion. And also hypoverview, it is showed a spindle, and as you rightly pointed out, it is epithelioid morphology, and also quite a frequent mitosis also, typical as well as atypical mitosis also very high. And is it sufficient? We need to look closely. As we go, there are some foci of necrosis, there are some spindly cells, and there are some round cell morphology. There are round cell, which was looking like it is in this cover, it is very obvious. There are some small round cell tumor. So you are seeing a biphasic tumor with a small round cell morphology as well as the spindle cell morphology. And it is showing you the features of malignancy, which is invading the skeletal muscle. And also it is here is a stagon stagon vessels. So where are we now? Where are we heading? What we are supposed to do? So we landed in a confused state. So this is the response we received from the participants of this schwannoma. I think I will straight away rule out. There is no cellularity and it is invasive pattern. I will straight away rule out this schwannoma. Lymphoma, spindle cells, very unlikely it will not show. Unless if it is a lymph node mass, if any sarcoma arising can be follicular dendritic cell sarcoma or interdigitating some cells, it can be. Are we dealing with rhabdomyosarcoma or any leiomyosarcomas? Or somebody said the metastasis. I don't know how the metastasis was thought. Or some of you said is it a myofibroblastic tumor? Or some of you said myxoid liposarcoma. Or some it is a we also particularly we had the DD of it is a newer entity which is described in WHO of ectomesenchyma, which is a recently upcoming tumor. So with this, all this differential diagnosis we had with IHC. This PAN-CK, which was negative, it is a ruled out carcinoma or any spindle cell carcinoma. However, age is 3-year-old, young. S100, is it a neural differentiation? Yeah, it is expressed. It is S100 positivity. Vimentin positivity, both the spindle cells as well as in the round cell morphology, round cell tumor, which is suggesting you that it is some mesenchymal tumor. Anyway, Vimentin we can't trust because it is one of the now we can take this Vimentin as such in isolation only for as a quality control. Otherwise, no use of only doing the Vimentin. Actin, there are some focal actin positivity tumor cells, and as well as it is taking up these vessels, which is taken up for this actin positivity. Then went ahead with some more markers. We try to exhaust all our IHC markers in this myogenin, which was taking positivity, which is nuclear positivity. Synaptophysin, especially in the round cell morphology, we looked at. So, with this particular intention, I will tell you why this round cell morphology, whether it is taken up synaptophysin, so which is negative in this case. You said the clear cell sarcoma, is it, can it be, it is also HMB45 SOX10 positivity. So SOX10 is negative, NKX 2.2 is negative, NSC is positive, which is suggesting that is it a neuroendocrine differentiation or neuroendocrine tumor. And CD56, which is positive, again neuroendocrine marker. TLE, because biphasic morphology, rule out with the stagon. Even with the particular intention, we did this myodemon, which is diffusely positive within the nucleus of both the cell, the round cells as well as the smooth muscle or spindly cells. CD34, which is positive, and Ki67 at a hotspot, which is look like around 20 to 30%, quite proliferating a tumor. So this is the exhaust. It is a batteries of test we did. Vimentin, CK, CD34, C100, almost 10 to 15 markers, which has expressed and which has helped it to arrive at some diagnosis. We were thinking in dilemma crossroads where we are heading. Is it ectomesenchyma or is it rhabdomyosarcoma? Rhabdomyosarcoma, if at all, if it is so, it is having spindle cell morphology as well as round cell morphology. It can be embryonal rhabdomyosarcoma, which can show spindle cell morphology as well as round cell morphology. So we were in dilemma: is it ectomesenchyma, which is a malignant tumor, rhabdomyosarcoma, and this ectomesenchyma is basically malignant tumor. It is a spindle cell sarcoma with the round cell morphology is a neuroblastic differentiation. So we went ahead with the WHO. What are the criteria says? What is this? Is it embryonal rhabdomyosarcoma or ectomesenchyma? As per this embryonal rhabdomyosarcoma, the essential criteria is primitive round cell and the spindle cell morphology with the scattered differentiation of rhabdomyoblast and positivity for desmin heterogeneous nuclear staining for myogenin and myod1, which was seen in undifferentiated cells, which is round cell morphology. If you look at this ectomesenchyma, it is also shows the same morphology like round cells, small round cells, as well as the spindle cell morphology. However, the round cell morphology should express. It will be expressing ganglioneuroma or ganglioneuroblastoma or neuroblast element, which will be expressing synaptophysin. So in this, our case, the even round cell, which is also showing you the myogenin or myod1 expression, and it is the round cell morphology which has not taken up the synaptophysin and neural marker. We ended with the final diagnosis of uh, embryonal rhabdomyosarcoma, posterior auricular swelling. There was lymphovascular emboli. Final diagnosis we offered was embryonal rhabdomyosarcoma. Actually, we had a tough time to differentiate ectomesenchyma. In a resource limited setup, it is very difficult to differentiate if you don't have enough pool of ISC markers in this case. It is just a theory. It is a rhabdomyosarcoma can be of alveolar embryonal, especially if it is round cell morphology with the spindle cell. It will pose a differential diagnosis, and whenever these tumor cells which is occurring in unusual place, so probably you may have to with collaborate with the clinician or treating physician or radiological assistant to make this a final diagnosis of this rare tumor whenever it is occurring in the unusual presentation. So this is the reference, which is it's a ectomesenchyma, which is beautifully given in the soft tissue tumor and the bone tumor, which is not there in the imaging. So this is finally we concluded as it is a embryonal rhabdomyosarcoma. So thank you.
Thank you, sir.
So good afternoon, everyone. This was the case which was given to SDMC. I'm Dr. Dheeraj, finally a postgraduate. So the history was given as 45-year-old female with frontal lobe mass. And with that, we got the whole mount view, which showed H&E sections like fragments of the tissue, which showing diffuse infiltration of the tumor cells. And these cells were arranged in nest and solid seeds, and they were actually divided by the fibrovascular septae, and also some of the areas were showing fibrovascular like arborizing blood vessels with thinning of it. Along with it, when we went to the high power, we saw the tumor cells which were pleomorphic, round to polygonal shape, which has distinct cell membrane, and it had moderately pleomorphic nuclei with coarse chromatin, and it was inconspicuous nuclei, and it had abundant amount of cytoplasm. And some of the areas were showing thinned out blood vessels also. Along with it, there were seen perivascular and interstitial collagen in it, with some of the areas showing blood vessels was surrounded by the tumor cells, which had a pseudo-rosette kind of pattern. Along with it, there was areas of necrosis with areas of hemorrhage, and also one of the area was showing area of reactive gliosis. With that, when we come to the microscopy, it was shown as H&E section studied shows fragment of tissue showing diffusely infiltrating tumors arranged in compact seeds and compact nest and solid seeds separated by delicate fibrovascular septa, and at places where the network of arborizing blood vessels which were thinned out, showing the resembling as in like chicken wire vasculature, and individual tumor cells were polygonal with distinct cell membrane with abundant clear cytoplasm and moderately pleomorphic nuclei with coarse chromatin, and inconspicuous nuclei also seen where the areas of hemorrhage and necrosis with focal areas of reactive glosses, and some of the areas also were showing edematous region with prominent perivascular and interstitial collagen were seen occasionally, and there was no Samoa bodies or mitotic figures or any fibrillary areas with microvascular proliferation or perineural satellosis were noted. So with that, we have given it differentials of clear renal cell carcinoma metastasis along with clear cell ependymoma with clear cell meningioma WHO grade 2 with oligodendroglioma and as grade 3. When we come to the like choosing like how points favoring and against we have gone. So metastasis, when we talk about the renal cell carcinoma clear cell variant, the points favoring were the nest and the seeds of polygonal cells with arborizing blood vessels along with hemorrhage and necrosis, and also the mass were present in the frontal lobe, and it has a very like metastasis happens of RCC in the frontal lobe. With against where there was absence of prominent nuclei. When we come to the ependymoma, it favoring points favoring where the large round to oval nuclei with along with the cellularity and the nest and seeds pattern of tumor cells, and also there was perivascular accumulation of the tumor cells in pseudo rosette pattern. Against was there was no presence of true rosettes. Clear cell meningioma, when we talk about the favoring where the same things as in like seeds of round or polygonal cells with abundant clear cytoplasm and bland to round oval nuclei with prominent perivascular and interstitial collagen. And against where intraparenchymal tumor, it is an intraparenchymal tumor. So oligodendroglioma, when we talk about, so points were favoring as in like the same thing, seeds and nest of pattern of polygonal cells with abundant clear cytoplasm, and there was perivascular accumulation of the tumor cells. And oligodendroglioma, when we talk about, it has a preponderance of happening in the frontal lobe, and points against with the absence of the perinuclear halos and calcification. So if we have to approach in this case, we should go with the IHC panel, as in like if METS clear cell renal carcinoma we are talking about, then PAX 8 it come positive with CA9 positive, and EMA will also be positive in it. And when we talk about clear cell ependyma, it will be S100. It will be positive with vimentin positive, and EMA will be strongly positive in it. And when we talk about clear cell meningioma, there will be vimentin positive with SSTRA, SSTR2A, and EMA is strongly positive showing in this. And when we go to the oligodendroglioma, it shows GFAP positive with IDH mutated type. So IDH 1 and 2 along with 1P Q19 should be present with it. And also there will be OLIG2, which will be positive with ATRX wild type and P53 wild type with Ki67 positive. So with that, we have come to the conclusion of clear cell renal cell carcinoma metastasis.
Yes. Okay. So the history given here was frontal lobe mass in a 45-year-old female, well discussed by Dr. Neeraj. He has shown the histopathology along with the positive and negative findings both in histopath as well as in IHC. So I will show how it came to us. It came as with the complaints of patient came with complaints of bilateral sensation of burning in both the eyes for the past 2 months, and the patient was suggested for MRI brain, where they found a left frontal lobe lesion, which was sized around 3 cross 3 cross 2 centimeters, with perilesional edema causing midline shift. So the clinical as well as their radiological imaging, they suspected high-grade glioma, that is a brain primary lesion. So the patient underwent frontoparietotemporal craniotomy, where they debulked the lesion and sent us multiple bits of the tumor tissue. As shown, this is a whole mount where you can see multiple tissues where there is normal brain parenchyma as well as the lesional or the tumor tissue seen. On higher power, we can see uniform cells. Basically, they are large cells with clear cytoplasm and small gland-like nucleus. They are arranged in predominantly nests or alveolar pattern or solid pattern. Similar morphology seen here, and the peritumoral response, that is reactive gliosis, is also visible. We can see peritumoral arrangement of the cells, or you can call it as thin fibrovascular septa in between the cells, which are dividing it into nests. On higher power, you can see individual tumor cells. They are polygonal or quite large, having bland or empty cytoplasm or a clear cytoplasm with a central or occasionally peripheral nucleus, which is bland hyperchromatic, showing a moderate amount of nuclear pleomorphism. You can see again, this lesion was also showed by Dr. Dheeraj, perivascular arrangement of the tumor cells. So again, higher power. If we see, if this was told as a kidney lesion, we would surely, without any doubt, call it as clear cell RCC. But this patient did not have any history. He came with primary lesion in the brain. So again, we still considered metastatic clear cell RCC as the DD, and another DD we thought of was hemangioendothelioma or hemangioblastoma, primary from the brain, which actually did not come up in any of the DDs which were submitted to us by the others. Along with that, we got extra DDs such as clear cell ependymoma, clear cell meningioma, or oligodendroglioma. So our lesion, which we thought first was hemangioblastoma, in this it is usually a well circumscribed tumor. You can see there is a differentiation between the normal brain parenchyma and the lesion, which was absent in our case, and lots of areas where there is dilated and congested blood vessels, which was again not seen in our case, but we still kept it in the DDs. Clear cell meningioma, yes, morphologically looks very much similar to clear cell RCC, but as we all know, meningioma is a dura-based lesion, and this lesion was not having any attachment to the overlying dura. Clear cell ependymoma, again, morphologically mimics the same, but perivascular durosis, which was also told by Dr. Dheeraj, is not seen in our case. Oligodendroglioma actually are smaller cells. The cell size is comparatively small than the other clear cell lesions, having the uniform small round nucleus with the fried egg appearance, which was not seen in our case. So we dispatched the histopathology as favors features suggestive of metastatic clear cell RCC, possibly from the kidney, because there was no known history of renal cell carcinoma in the kidney. Differential diagnosis was given as hemangioblastoma. We went ahead with IHC. So GFAP for brain origin of the lesion was negative. You can see the normal area of the brain, which shows positivity, and the tumor cells are negative. PAN-CK was positive, suggesting an epithelial origin tumor. PAX8 also was positive because we thought of RCC and it has nuclear positivity.
Further, CD10, vimentin, and CA9, all three which are markers of clear cell RCC, came out to be positive. For hemangioblastoma, there was inhibin, which turned out to be negative in the case. So final diagnosis, we gave it as metastatic clear cell renal cell carcinoma, metastatic to the brain, that is T4 stage, going to directly frontal lobe lesion. Thank you.
Okay. Good afternoon, everyone. I am Dr. Rebecca, a postgraduate student from Sri Atal Bihari Vajpayee Medical College and Research Institute, Bangalore. First, coming to the history of the case, I got the case of D3, 69-year-old male having a prostatic biopsy. First, coming to the whole mount view, the whole mount view shows 2 long cores with the rest of them showing 10 cores which are fragmented. Coming on to the low power view, in low power view, we will see that there is presence of atypical cells which are present in a vague glandular pattern with nascent sheets pattern, and they're separated by fibrous stroma. In high power field, we will see that atypical cells are spindle or ovoid in shape, having hyperchromatic nuclei with inconspicuous nucleoli. Another section of the core biopsy shows sheets of atypical cells, and these atypical cells they also show vague glandular pattern with having spindle shaped cells with spindle and ovoid shaped cells. In another picture, we saw that there is presence of some few mitotic figures. There is also seen the fibroid host tissue fragments with areas of hemorrhage, and in one area there is presence of uh, in one area there is presence of neuronal invasion, perineural invasion. And in some area, there is presence of atypical spindle cells which having hyperchromatic nuclei. So coming to the summarization, section studied shows tumor cells which are arranged in nest, sheets, and vague glandular pattern. Individual cells, they are oval to spindle shape, hyperchromatic nuclei, inconspicuous nucleoli with indistinct eosinophilic to clear cytoplasm, and they are separated by intervening fibrous septa. The tumor cells, they are seen surrounding the blood vessels, the muscles, and the nerve bundles. Also seen are areas of hemorrhage along with fibroadipose and fibromuscular tissue fragments. So we have come to the pathological diagnosis of adenocarcinoma, grade group 5, with a Gleason score of 4 plus 5, 9. Probable subtype is sarcomatous variant, and that needs to be confirmed by IHC. The differential diagnosis which we have given is prostatic stromal sarcoma, prostatic leiomyosarcoma, and prostatic solitary fibrous tumor. So coming now to the discussion, the difference between the prostatic adenocarcinoma and sarcomatoid carcinoma. Prostatic adenocarcinoma is seen in age group of above 50 years of age, whereas in sarcomatoid also it's seen above 60 years of age. In sarcomatoid, it is mainly seen prior to a person who is having SNR type of adenocarcinoma. In presentation, in prostatic adenocarcinoma, there is presence of elevated prostatic specific antigen and urinary obstruction. In sarcomatoid carcinoma, there is rapidly enlarging pelvic mass, hematuria, urinary obstruction, whereas the PSA level is normal. The cells of origin in prostatic adenocarcinoma is they are from glandular epithelial cells type, whereas in sarcomatoid type, they are biphasic tumor having epithelial as well as a sarcomatoid component. The architecture in prostatic adenocarcinoma is they are gland-forming infiltrative pattern with loss of basal cells, whereas in sarcomatoid, they are biphasic pattern, glandular in adenocarcinoma, whereas in sarcomatoid or spindle cells in high-grade sarcoma. Coming to the cytology, they are of uniform cells with prominent nucleoli showing moderate atypia. In sarcomatoid carcinoma, they have marked pleomorphism, which can be mistaken as a bizarre giant cell type. The stroma in prostatic is fibromuscular stroma with desmoplasia, whereas in sarcomatoid, they may mimic leiomyosarcoma or chondrosarcoma or other any heterologous component. The stains which we can do in adenocarcinoma is the stain for epithelial markers like prostatic specific antigen, prostatic specific acid phosphatase, NKX3.1, prostin, androgen receptor, ERG, human glandular kallikrein 2, and MAGR. In sarcomatoid, the epithelial markers like cytokeratin, EMA, they are often positive in some cells, and PSA may be negative in sarcomatoid cells. Thank you.
Good afternoon. I hope you can see my screen. Thank you, Dr. Rebecca. That was a very good presentation. To continue with we had a 69-year-old male who came with a prostatic biopsy for the first time. And the slide given to you was the slide from the right lobe. So we had around 4 cores of, yeah, 5 cores on the right side and around 6 cores on the left side, which probably got fragmented during the processing. So we received the specimen in 2 containers. Containers were labeled as right prostate and left prostate, and they were embedded in the respective numbers, that is 3665 numbered and A. A microscopy, I think Dr. Rebecca has done a in detail description, which I will not repeat. So we saw multiple sections showing tumor tissue in 5x5 cores. The tumor cells are seen in diffuse sheets. The tumor cells have a dark hypochromatic nuclei at places and show nuclear pleomorphism. Perineural infiltration is also seen. Focal areas show necrotic debris. So we called it a features are suggestive of Essner adenocarcinoma prostate, 5 plus 5, the 10, that is, it belongs to the grade group 5. Now, the second container, which was from the left prostate, it showed 6 cores. This we had not sent it to you all for. We had not sent the slide to you. So the tumor cells are seen predominantly in diffuse sheets. The tumor cells have dark hypochromatic nucleus and show nuclear pleomorphism. Karyorectic debris are noted amidst the tumor cells. Here also, we called it a high grade, grade group 5, SNR adenocarcinoma of the prostate. But because of some amount of nuclear molding, little overlapping, high NC ratio, we had our doubts. So we got a IHC done. Now, the differentials given by y'all, you have adenocarcinoma of the prostate, urothelial carcinoma, small cell carcinoma, neuroendocrine carcinoma, polydifferentiated carcinoma, small cell neuroendocrine carcinoma, metastasis, and SNS adenocarcinoma. So now, this is the histopath final impression, which we gave from the right prostate. Features are suggestive of Essner adenocarcinoma prostate, grade group 5. All cores showed tumor tissue, whether diffuse or singly. Perineural infiltration was noted. Container 2 from the left prostate also we gave it as a features are suggestive of Essner adenocarcinoma, but simultaneously we asked for a IHC. Now coming to the IHC results, I'm sorry about the slides, I couldn't get the pictures. The right lobe, first stain we did was PSA. The right lobe showed patchy weak positivity, whereas the left lobe was negative. The NKX 3.1, now most of our stains, we have classified them as right lobe 4 cores and left, and 1 core shows a different IHC response. So in the NKX 3.1, the right lobe 4 cores were positive and 1 core was negative, which is obvious as you see it in the picture. The left lobe was negative. A marker, right lobe showed patchy weak positivity, whereas the left lobe was negative. P63, right lobe moderate patchy positivity was seen, that is aberrant. And in the left lobe, it was a very strong positivity, as you can all notice. This is a repeat. Now here, this is a more hyper view on the right side where you can see the NKX 3.1 showing positivity. The LCA on both the lobes, the right lobe as well as the left lobe, was negative. Synaptophysin, we did right lobe, 4 cores were negative and 1 core was positive. And the left lobe shows positive and positivity was strong and diffuse. Chromogranin, again the right lobe, 4 cores were negative and 1 core was positive. The left lobe shows positivity. I talk about CD56. The right lobe 4 cores were negative. Here it's very obviously seen, and 1 core is positive, whereas the left lobe shows all the cores were positive. It was strong and diffuse. KI67, right lobe shows 50% average and left lobe showed 90% average. So your immunohistochemistry interpretation, PSA result in right lobe 4 cores only. It was patchy weak positive. The left lobe 6 cores and right lobe 1 core was negative. A marker, patchy weak positivity in 4 cores of the right lobe, whereas it was negative in left lobe 6 cores and right lobe 1 core. P63 was moderately patchy positive in the 4 cores of the right lobe, whereas strong positivity was seen in left lobe 6 cores and right lobe 1 core. NKX 3.1 was positive again in the 4 cores of the right lobe, and it was negative in the left lobe and 1 core of the right lobe. The LCA was negative in both right and left lobe. Synaptophysin was negative in the right lobe and positive, which was strong and diffuse in the left lobe and 1 core of the right lobe. Chromogranin was negative in 4 cores of the right lobe, whereas it was positive in 6 cores of the left lobe and 1 core of the right lobe. CD56 also showed negativity in 4 cores of the right lobe and positivity which was strong and diffuse in 6 cores of the left lobe and 1 core of the right lobe. KI67, 50% average, 90% average. Finally, 90% average was seen in the left lobe and 1 core of the right lobe. Impression of the final diagnosis, the immunohistochemical features are suggestive of mixed carcinoma of the prostate. That is adenocarcinoma, Gleason score 5 plus 5, 10, grade group 5, present in 4 cores of the right lobe, and a high-grade neuroendocrine carcinoma, present in 6 cores of the left lobe and a single core of the right lobe. So this was the final impression. Now this is now going to the discussion. I have not too much talked about the histopathology. This is just the WHO chart of all the markers, the immunohistochemical markers of the prostatic adenocarcinoma, which we have done quite a few. This is the Gleason score, Gleason's pattern. Ours mostly fell, the adeno component fell into the pattern, mostly 5. Minimal glandular differentiation, comprising of solid sheets, cords, small solid cylinders or single cells, or solid cribriform papillary structures with central necrosis. So, and finally, this is the latest classification where we have the grade group. It fell under the grade group 5. So now we have the neuroendocrine carcinoma of the prostate. Okay, most high-grade Gleason score prostatic adenocarcinoma show focal neuroendocrine differentiation. So the neuroendocrine differentiation can be both small cell kind of neuroendocrine differentiation and large cell neuroendocrine differentiation. And it can be admixed with areas of typical prostatic carcinoma. Treatment-related neuroendocrine carcinoma of the prostate was ruled out because the person has come for the first time and it was a first-time diagnosis. Patient had not undergone any treatment. And finally, all mixed tumors, mixed carcinomas of the prostate have poor prognosis. So this is the WHO picture which I've downloaded. This is the mixed carcinoma of the prostate, one side showing the adenocarcinoma, which is a high-grade type, and the other side showing darker cells, which is of the neuroendocrine morphology. The B section shows, this is again from the WHO, positive chromogranin seen in neuroendocrine areas and negative chromogranin stain seen in prostatic adenocarcinoma areas. Now, if you see the left, 1 core of the right side, which was there in the slide given to you, and all the cores on the from the left lobe. It has this um, tumor cells with high NC ratio, nuclear with salt and pepper chromatin, may not be appreciated, but there is high mitotic activity and tumor necrosis is also noted. This picture looks more like our neuroendocrine areas in the mixed carcinoma of the prostate. So final impression, it's gone as mixed carcinoma of the prostate, that is both SNR adenocarcinoma and neuroendocrine carcinoma. Thank you.
Thank you, ma'am, for the discussion. The next presenter is Dr. Abinya. By the time she gets ready, we will see few more spotters. Just write it in the chat box. Whatever you think this gross specimen is. Sir, answer ಎಂತ ಇದೆ ಸ್ವಲ್ಪ ಹೇಳಿ ಬಂತ Okay, this is gross of hydatid cyst. Identify the scientist. No. No, ma'am. No, ma'am. So he's Edwig Klebs. He was the one who discovered Corynebacterium diphtheriae, which is also called Klebsiella. This is a gross specimen for all the exam going PGs. Yes. Yes, it is pigmented villonodular synovitis and CSF fluid. Okay. So TB meningitis, cobweb appearance. So we'll go ahead with the third case. Yes. Dr. Abhinaya, please
Hello,
start
ma'am.
sharing
Is
your
it
screen.
audible?
Yes, it's audible. You can go ahead. Visible for you?
One second, ma'am. Yes, ma'am.
All
Thank
right.
you.
No problem.
Shall I start, ma'am?
Yes, please start. I'll be muted, so you just tell me when I have to change the screen for you.
Yes, ma'am. Good afternoon, everyone. I'm Dr. Abhinaya, second year postgraduate from Dr. B.R. Ambedkar Medical College, Bangalore. I'm going to present case D4. So, history 30 years male, L2 to L3, intradural spinal mass. Next slide, ma'am. In scanner view, shows a partially encapsulated neoplasm with a peripheral calcification is seen. Moving on to the next slide, ma'am. Next, ma'am. Moving on to the low power view, partially encapsulated neoplasm with tumor cells are arranged in sheets and areas of hemorrhage is seen. Next slide. Here you can see the tumor cells are arranged in solid sheets, papillary like pattern. Next slide, ma'am. Also, a Zellballen pattern is seen where tumor nests are separated by thin fibrovascular septae. The next slide. So here we can also see the peripheral calcification next to the neoplasm. And in this image, low power, previous one. In this image, low and high power view showing a cell balance pattern where tumor nests are separated by sustentacular cells and fibrovascular septae is shown. Next slide. In low power view showing the pseudocytes where tumor cells are separated by tumor cells are arranged in a pseudorosette form and slit like vascular spaces are seen in low power view. Next slide, ma'am. Moving on to the high power, perivascular pseudorosettes characterized by tumor cells arranged radially around the blood vessel is shown here. Next. So in this pseudorosette and cell balance pattern is seen next to next. Next slide, ma'am. So individual tumor cells are round to oval with moderate eosinophilic cytoplasm and round to oval nuclei showing finely stippled and salt and pepper chromatin and inconspicuous nuclei. Next slide, ma'am. In this, we can also see the hemosiderin deposits in low and high power view. Next slide. In this, intratumoral calcification and calcification within the capsule is noted. The next slide. Also, few areas of focal areas of hyalinization and sclerosis is seen. Next slide, ma'am. In summary, section studied shows a partially encapsulated neoplasm composed of tumor cells arranged in solid sheets and cell-balanced nested arrangement of cells separated by delicate fibrovascular septae. Focal areas show papillary-like pattern with occasional pseudorosettes. The individual tumor cells are round to oval with moderate amphiphilic cytoplasm and round to oval nuclei showing finely stippled salt and pepper chromatin and inconspicuous nucleoli. The stroma show slit-like perivascular spaces with focal areas of hyalinization and sclerosis. Foci of hemosiderin deposits and calcification are also noted. No significant mitotic activity or necrosis is identified. So, differential diagnosis is spinal ependymoma or neuroendocrine tumor. To further ancillary tests are needed for further confirmation. So, glial fibrillary acidic protein positive in ependymoma and epithelial membrane antigen which shows a perinuclear dot-like or ring-like positivity seen in ependymoma. For chromogranin A, synaptophysin S100 protein, focal positivity is seen in neuroendocrine tumors. That's it, ma'am. Thank you.
That was wonderful presentation. You covered almost every finding in the slide. So this case is discussion 4 slide. History given was 30-year-old male presented with intradural spinal mass. So patient presented with complaints of tingling sensation of bilateral lower limb and pain which is radiating to lower back to bilateral lower limb since 2 months. MRI spine was done, the image I could not get it. So the report said well-defined ovoid intradural lesion below the conus medullaris at L2 L3 level, measuring 3.5 into 1 into 1.4 centimeter. The lesion was displacing and distorting the cauda equina. The impression was given as well-defined enhancing ovoid intradural lesion, likely myxopapillary ependymoma. So we got the specimen of laminectomy with the excision of the lesion. Grossly, it was 2.3 centimeter. We gave in 2 sections. So this is the whole mount view, which can, as you said, it is a partially encapsulated lesion and it is quite vascular. We can see the nests of tumor cells and we can see the focal papillary like arrangement and in high power you can clearly see there are few number of papillae which are having vascular core. So this is a perivascular arrangement of the tumor cells, which is called as perivascular pseudo rosette, where you can see the nucleus which is arranged radially around the central blood vessels and nucleus is pushed away from the blood vessel. So that is perivascular rosette, which can be seen in ependymoma. So few places we got true ependymoma like rosettes also with central lumen. So here you can see the pattern where there is lobules and nests of the tumor cells separated by the spindle cells, and also there are some blood vessels, network of thin capillaries, so which is called as Zellbalan pattern. Individual tumor cells had a round to oval nucleus with the clearly stippled chromatin. So areas of calcification was seen, and also hemosiderin-laden macrophages were seen at the periphery of the lesion. So based on the histopathology, our first DD was ependymoma, as it is a most common tumor, and also radiologically they said it is ependymoma. The second DD was paraganglioma, which is also called as neuroendocrine tumor of the cauda equina, because of the pattern which is Zellbalan pattern, which we appreciated in the histopathology. What we received as responses are, the most common one is ependymoma, myxopapillary and spinal ependymoma. However, in this case, there were no myxoid areas, although papillae were seen. The next DD what we received is paraganglioma or neuroendocrine tumor, and few have responded as meningioma. But here in ISC, first we went ahead with the first line of markers for ependymoma, as it was our first DD. So GFAP was negative, EMA was negative, both were negative. So both are positive in ependymoma. Whereas S100 shows diffuse positivity. So our first DD was ependymoma, but as GFAP was negative and EMA was negative, in ependymoma, EMA will be having perinuclear dot-like positivity that was not seen, but S100 was diffuse positive. So based on this, ependymoma is ruled out because of GFAP negativity and EMA negative. So what next? So we have to go ahead with the next set of marker. So the next DD for us was paraganglioma. So when you go back to S100, which we did in the first line, so we can see the tumor cells are positive, but something we can appreciate here is in between the tumor cells, there are some cells which are strong positive. So that is highlighting the Zellbalan pattern, where the sustentacular cells which are showing strong positivity. So we went ahead with the second line of marker, synaptophysin and chromogranin both showed strong positivity. So synaptophysin showed strong positivity. Chromogranin was also positive. So we did SOX10 because S100 was positive. We wanted to rule out as it is a spinal lesion, schwannoma also we wanted to rule out. But what we can appreciate here is the round to oval cells are negative, but in between those S100 strong positive cells are also SOX10 positive, whereas the round to oval cells are negative. So those strong positive cells are actually the sustentacular cells. GATA3 we did, as paragangliomas are known to be GATA3 positive, but here it is negative. Ka67 was low, and also in histopathology, mitotics were very less, and Ka was around 5 to 80% in hotspots. So final diagnosis based on morphology and ISC was cauda equina neuroendocrine tumor. Previously, it was known as paraganglioma, but now it is considered as neuroendocrine tumor. So it comes under WHO CNS grade 1. So why it is not considered as paraganglioma? It is a neuroendocrine tumor which is arising from the neural crest cells of cauda equina, which was initially reported in 1970. From then, around 300 cases are being reported. Their typical presentation is intradural mass, and patient will present with back pain, and they don't present with neuroendocrine tumor syndrome like pheochromocytoma. So they are not distinguishable from schwannoma or ependymoma radiologically, and these paragangliomas which are arising from the spinal canal are molecularly and histogenetically different from paraganglioma or pheochromocytoma which are happening outside the CNS. And almost all of these paraganglioma of the spine are sporadic cases, whereas around 40 to 50% of paraganglioma outside the CNS are actually hereditary, inherited, associated with various syndrome. So on histopathology, as you know, it shows Zilberman pattern, and there are two types of cells: chief cells, which expresses synaptophysin chromogranin variable S and rate, and pan-CK. Pan-CK we did in this case, which was negative. Sustentacular cells will show S and rate and also SOX10 positivity. But unlike paraganglioma of outside the CNS, they are GATA3 negative, whereas other paragangliomas are GATA3 positive. Proliferation markers have the significance of proliferation marker is not documented in WHO, and according to WHO, it is grade 1 lesion, which are curable with excision with very rare recurrence and very rare metastasis, whereas the one which are outside the CNS are known to have metastasis in 10 to 20% of the cases. So this is the reference, which is WHO 5th edition. Thank you.
Uh, can you see my screen, ma'am?
Yes. Yes, you can start.
Yeah. Good afternoon, everyone. Myself, Dr. Khushvinderjeet Singh Sra, final year postgraduate student from SSIMS. Case provided to us was D5. Coming to the history provided, 68 years male, cervical lymph node. This is the scanner view of the slide provided to us. Coming to the low power view, we were able to see extensive areas of necrosis, hemorrhage, and a viable area. Coming to slight higher power, we can see tumor cells arranged in cohesive sheets and solid nests. Coming to the high power, we can see the tumor cells are round with hyperchromatic nucleus with indistinct nucleoli and moderate to scant amount of eosinophilic cytoplasm with indistinct cell borders, giving a syncytial appearance. So few areas also showed prominent non-neoplastic lymphoid component comprised of mature lymphocytes and plasma cells seen in association with the malignant epithelial component. We were able to make out frequent mitosis, which was typical and atypical type. 5 to 10 mitosis per high power field were observed. We were able to see few large cells with abundant eosinophilic neoplasm with lobulated nucleus. We thought them as tumor giant cells. Few areas also showed stippling of nuclear chromatin, giving so-called salt and pepper appearance. We were also able to see smudgy material in few areas, which we thought of as crushing artifact. So areas of large areas of necrosis and hemorrhage was also observed in the sections. So to summarize the findings, complete effacement of lymph node architecture with vast areas of necrosis and hemorrhage intermingled with viable areas were seen. Cells are arranged cohesively in sheets and solid nests. Individual cells are round to oval with hyperchromatic nuclei. Moderate to scant cytoplasm and indistinct nuclei was seen. Frequent mitosis was noted, both typical and atypical, accounting for 5 to 10 per high power field. Lymphocytes and plasma cells infiltrating between tumor nests, giving lymphoepithelial pattern. Dispersed in between were few larger cells with abundant eosinophilic cytoplasm with lobulated nucleus, query tumor giant cells. So we thought of as metastasis in lymph node. Our DDs were nasopharyngeal carcinoma, non-keratinizing, undifferentiated type, and small cell neuroendocrine carcinoma. So we will discuss about the nasopharyngeal carcinoma, non-keratinizing, undifferentiated type. The features favoring in NPC were the age, which was 4th to 6th decade. It can also occur in children, but males were more common. The most common lymph node involved in this case is cervical. And coming to the microscopic features, there is absence of keratinization, syncytial growth pattern. Cohesive and non-cohesive cells can be seen. The neoplastic cells are characterized by the presence of round nuclei, prominent eosinophilic nuclei, dispersed nuclear chromatin, and scant eosinophilic to amphiphilic cytoplasm. There is increased mitosis, including atypical forms are present. Prominent non-neoplastic lymphoid components can be seen. So coming to features which can favor small cell neuroendocrine carcinoma are, it also occurs in 6th to 7th decade. Males are more commonly affected. The most common lymph nodes which can be affected are cervical lymph nodes and supraclavicular lymph nodes. Coming to the microscopic features, tumor is composed of small cells arranged in cohesive sheets and nests which are undifferentiated. The cells are round and occasionally fusiform with very scant cytoplasm and hyperchromatic nuclei without prominent nucleoli. Crushing artifact and DNA encrustation can be seen on the vessel walls, giving it so-called azopardy effect. Slightly larger cells with somewhat more cytoplasm can be seen with brisk mitosis. So these are the IHC markers which can be done. So in NPC, cytokeratins, including pan-cytokeratins and high molecular weight cytokeratins can be positive with P63 and P40. Coming to small cell neuroendocrine carcinoma, we can see chromogranin, synaptophysin, NSE, neurofilament, and CD57 can be positive. Coming to the gold standard test, which is in situ hybridization, in case of NPC, EBER will be positive. These are my references. Thank you. So we thought of both the DDs.
Yes, thank you for your presentation. I'm Dr. Sanjana, Senior Resident from KCIAPM Medical Academy. So the history which we gave was 68-year-old male presenting with cervical lymph node enlargement. So directly going to the histopathology. So these were the slides, images which we shared. So as we can see, when we went to the higher power, we could see the tumor here is arranged in sheets. Yes, and again when we go to still higher power, so these were medium to large tumor cells which are pleomorphic, having so these were medium to large tumor cells arranged in sheets having vesicular, chromatin, and few showing prominent multiple nucleoli. Yes, and you can see many increased typical and atypical mitotic figures, and as you told, areas of necrosis and hemorrhage was also seen. So based on this morphology, same thing again. So based on this morphology, we gave an impression of large cell lymphoma, and we have told we need to go back and do IHC workup, right? So the first set of panels which we did for IHC was CD45, CD3, CD20 as shown, and pan-CK. All the four markers were negative. So we didn't know where to start from. So we went again and did few other markers. So next was PAX5, which was weak positive. We did ALK. This one is important. This one was positive. Next, we did CD79A. Then we did synaptophysin. Yes, you also said that was salt and pepper chromatin, right? So we went and did synaptophysin also. So then the next set of markers which we did was for plasma cells. This is CD138, which had taken a positive. Next, even we went ahead and did CD38 MUM1, which was negative. Next, the fourth set of panel which we did was kappa and lambda. Kappa has taken more than the lambda. Then we did Chi67. So Chi67 was 80 to 90%. So this was our final report where all the markers. So we gave the diagnosis of ALK positive large B cell lymphoma of the right cervical lymph node. So coming to the discussion, so these are large monomorphic neoplasm of large B cells with a plasmablastic phenotype and ALK expression due to ALK rearrangement. So majority of the patient, almost 70 to 80%, they present as cervical lymph node enlargement. The other sites which can be involved are upper GI, brain, and aerodigestive tract, liver, spleen. So these are the other locations. So patient will present to you with asymptomatic lymphadenopathy, and two-thirds of the patient may have even B symptoms. So serum lactate dehydrogenase and beta-2 microglobulin levels are commonly elevated, and they can be localized or disseminated disease. 20 to 35 patient will have staging bone marrow evaluation, which is positive. So again, gross like other tumors. So this will have fish flesh appearance. Hemorrhage and necrosis can be seen. So almost the same morphology which I described earlier as in our case. But one more morphology which can be seen is the cells can have eccentrically located nuclei and dissemble plasmablasts. This is other morphology which they can have. And next few of the cells can be they can look like RSL. Then areas of apoptosis and necrosis also can be seen. So prognosis is not that good for all this patient. So you can so usually they'll be treated with systemic chemotherapy using CHOP regimen. Yes, the DD as given in WHO is plasmablastic lymphoma, HHV8 positive diffuse large B cell lymphoma, and primary effusion lymphomas. So this is my reference, and thank you.
Next slide, please. The history given is 55-year-old male with left frontotemporal cystic mass. Next slide, please. In the scanner view, we can see cohesive clusters of tumor cells in nest and storage sheets. Tumor cells even seen invading into the brain parenchyma, and while a cystic cavity is noted, which is also been lined by the tumor cells. Probably the tumor is originating from the cystic liner invading into the brain parenchyma. Next slide, please, ma'am. In higher power, we can see the tumor is arranged in a papillary fronts with fused papilla and prominent fibrovascular cores with vascular channel seen going into these papillae. Next slide, now. In further areas, we can see the dense chronic inflammatory infiltrate been there around these tumor cells. And a few areas of rosette formations also been seen. It could be a possibly a transverse cut of the papilla, which is there, probably a pseudo rosette around the blood vessels. Next slide, please. Here we can see areas of necrosis. In the tumor areas, we can see brisk mitosis and marked cellular atypia in the form of pleomorphic I mean, they are vesicular nuclei. I'm having inconspicuous nucleoli. Next slide, please. In our differential diagnosis, I've kept metastatic deposits from high-grade carcinoma as number one, and other DDs includes choroid plexus carcinoma and anaplastic ependymoma based on morphology. As however, these two entities I've kept in the lower grade because they are most common in children and unlikely or maybe very rare in adult in an age of 55 years of male. So further diagnosis will be made based on immunohistochemistry. That's all. Thank you, ma'am.
Good afternoon, everyone. Thank you, Dr. Arijit. It was a good presentation. So I'll take you through this case. Discussion case 6. It was the history he provided was 55-year-old male, and he presented to us with complaints of slurring of speech and dizziness of 1 week duration. Multiple tissue bits were received, which altogether measured 2 into 1.5 into 0.5 centimeters. The MRI showed two well-defined altered signal intensity lesions, larger in the left frontal lobe, measuring 6.7 in the largest diameter, and smaller in the left temporal lobe, measuring 2 centimeters in the largest diameter. The lesions were predominantly cystic with irregular nodular and thickened walls, and it was suggestive of metastasis. So this is the MRI picture. You can see the lesions, the large lesions, and they're also showing a lot of deformity and with also the pressure effects on the brain. So this is the entire scanned view of the sections. What you can appreciate is it is a very blue tumor, and it is well demarcated from the surrounding brain parenchyma. At higher power, you can again appreciate the basaloid tumor, and it is showing nests as well as these nests are coalescing together to form broad sheets, and you can see that they are nicely demarcated from the surrounding brain tissue. At higher power, you can see these tumor cells, they are round to, I mean, they have a high NC, they're very mainly a basaloid appearance with a high NC ratio. The nucleus is almost entirely filling the cell and you can hardly see any cytoplasm. Nucleus is round to oval and it is showing a hyperchromatic appearance. Here again, you can see at high power, you can see the cells are round to oval with a round to oval nucleus, hyperchromatic and high NC ratio. Some of these nests are showing peripheral palisading appearance. Okay, you can see the tumor cells which are arranged in a palisading manner at the periphery. Also, you can show in these, you can see in these some amount of necrotic debris can be seen amidst in the center of these tumor nests. So this is another view showing you the tumor cells. So you can see that the cells showing very a lot of mitosis. You can see the tumor is showing a lot of mitosis, and you can see all these karyotic debris. And this view showing you plenty of mitosis. So I put a arrow. You can see the multiple mitotic figures, as well as you can see some necrotic debris or karyotic debris which is seen in the center of these tumor cells. Okay, and some of these are also, again, some of these nests are also showing this kind of peripheral palisading of the tumor cells. So what do we have here? To summarize, we have tumor cells well demarcated from the brain parenchyma, infiltrating as broad sheets and nests. Some areas you are seeing papillary pattern, and I think so you can see a vague papillary pattern is seen here, and some kind of a pseudo rosette with central blood vessel can also be seen in some of these areas. So basaloid appearance of cells with closely packed round to oval cells showing high NC ratio, nucleus showing fine to coarse chromatin, inconspicuous nucleoli, and scant pale cytoplasm. And focally, you can see peripheral palisading, brisk mitosis, and necrosis can be seen in the tumor nests. So at this point, our differentials were mainly, we also thought of metastatic lesion to the brain, and we thought of metastasis from high-grade neuroendocrine carcinoma, basaloid or poorly differentiated squamous cell carcinoma, or a poorly differentiated adenocarcinoma. The differentials that we received also, most of the metastasis was high on the list, and many of them you have given it as metastatic lung carcinoma and metastatic urothelial carcinoma, and some of you have written metastatic neuroendocrine carcinoma. The other DDs that we received were papillary craniopharyngioma. Papillary craniopharyngioma usually shows squamous nests, but they are more they are WHO grade 1 tumors and show more benign proliferation of squamous cells. Papillary meningioma can be a DD if it is located in the if it's a dura-based lesion, or if it is located in the intraventricular location. Then it is also a high-grade aggressive tumor. But since our tumor was predominantly intraparenchymal, we did not think of papillary meningioma. Glioblastoma of the epithelioid type is usually shows pleomorphic cells with abundant eosinophilic cytoplasm and rhabdoid or epithelioid morphology. But ours was mainly a very blue or a very basaloid kind of appearance. So that was also we did not consider in our list. Pleomorphic xanthoastrocytoma actually shows very pleomorphic cells and has a spindle and polygonal as well as multinucleated giant cells. We did not see all of these in the tumor. And anaplastic ependymoma can also be a DD. Anaplastic ependymoma, the term is not used anymore in WHO. Usually it is given as ependymoma grade 3. And depending upon its location, sometimes it can also be a DD. However, this tumor, it is not related to the ventricles, this tumor. And later IHC also proved otherwise. So we will go to the IHC findings. So this is the IHC that we did. GFAP was negative as expected in the tumor cells. Pan-cytokeratin was diffuse and strong positive. Synaptophysin showed only focal patchy positivity. CD56 was also focal and patchy positive. And chromogranin was negative. Coming to the squamous markers,
P63 was strong nuclear positive, but in a patchy sort of way. Similarly, P40 also showed patchy, strong nuclear positivity. CK5R6 also was positive, but patchy positive. And P16, because we wanted, in case it was a squamous carcinoma, we wanted to rule out HPV associated. So we had done P16, which turned out to be diffuse log positive. The common metastases to the brain include from the lung or from colorectal carcinomas, and also melanomas, renal cell carcinoma. So those things, for those we had done additional markers. So TTF1 was negative, CK7, CK20 were negative. We also wanted to rule out NKX prostate, so NKX 3.1 was done, and GATA3 because we also had a suspicion of urothelial carcinoma, but GATA3 was also negative. And Ki67 was very high, more than 80% in the tumor. So now we had a tumor which had a very basaloid appearance and has a co-expression of keratins and neuroendocrine markers. So we were wondering what could be the other markers that we can think of. And so we thought of a rare possibility of Ewing sarcoma, which can also show this kind of a basaloid morphology and simultaneously express keratin and neuroendocrine markers. So this is CD99. CD99 showed diffuse membranous positivity throughout the tumor. NKX 2.2 was showing patchy positivity. This kind of positivity was present elsewhere also, but I have taken only a focus where we are seeing multiple cells which are showing positivity. And FLY1 also showed moderate diffuse positivity in the tumor cells. Neuron specific enolase was also positive. And thinking of polydifferentiated carcinoma metastasizing from head and neck, we did INI1 to rule out SMARCB1 deficient carcinomas, but INI1 was retained. So now what do we have? We have a basaloid tumor with high-grade histological features like necrosis and brisk mitosis. Tumor cells are showing peripheral nuclear palisading, and immunohistochemistry shows positivity for CD99, FLI1, focal NKX 2.2, pan-cytokeratin, CK56, P63, P40, focal positive synaptophysin, and CD56. So in view of these expression of these markers, we thought of a metastasis from, or we concluded it as a metastasis from adamantinoma like Ewing sarcoma. However, for confirmation, we asked for molecular studies for EWSR1 FLI fusion to look for the presence of EWSR1 FLI fusion. Unfortunately for us, the patient deteriorated soon after the surgery, and we could not go ahead with further uh, evaluation. And also, we had asked for looking for metastasis in other for primary in other locations in the head and neck. That also could not be done because we did not. I mean, patient. I mean, they took a discharge against medical advice, and we could not further evaluate the patient. So when we looked up for the cases of adamantinoma like Ewing sarcoma, it is a rare tumor which has been recently described in the WHO, and metastasis is also very rare. But we found one series from Tata Memorial Hospital in which 7 patients were studied, and one of them had shown metastasis to the brain. So this was the only case we found in literature which showed a metastasis, and this was confirmed by EWSR1 rearrangement by molecular studies. So Ewing sarcoma, as all of you know, is a tumor which harbors translocation between 11 and 22, and it's defined by a fusion between FET family and ETS family of genes. The members of the FET family include EWSR1 and FUS, and ETS family includes FLI1 and ERG. Of this, the most common is EWSR1 FLI1 gene fusions. So adamantinoma like Ewing sarcoma is described now as a subtype of Ewing sarcoma, and it's a rare malignant tumor characterized by this translocation along with complex epithelial differentiation. So epithelial differentiation can also be seen in Ewing sarcoma in about 30% of cases. However, this strong positivity for P40, the squamous markers P40 and P63 is not seen in um, Ewing sarcoma, and it usually points to diagnosis of adamantinoma like Ewing sarcoma. Most common site is in the head and neck. However, it has also been described in the abdominal cavity. Histologically, it is characterized by infiltrative sheets, nests, and lobules of baseloid cells, which is embedded in a prominent fibromyxoid or hyalinized stroma. Usually, the tumor cells show nuclear palisading and rosette formation with prominent mitosis and necrosis. One feature which can be sometimes seen is formation of keratin pearls, which we did not see. Immunohistochemistry shows the conventional Ewing sarcoma markers like CD99, strong membranous CD99 expression, and nuclear NKX 2.2. High molecular weight cytokeratin P63 and P40 will be positive here. Focal positivity for neuroendocrine markers can be seen most commonly synaptophysin. So it has been said that concomitant positivity for pancytokeratin P40 and CD99 is identified by definition in adamantinoma like Ewing sarcoma, and it is relatively specific for this diagnosis. The differentials, because this adamantinoma like Ewing sarcoma is common in head and neck. The tumors of the head and neck like nut carcinoma, basaloid squamous cell carcinoma, high-grade neuroendocrine carcinoma are all differentials in this and need to be ruled out. So nut carcinoma is a very good morphologic mimic, and it shows almost similar features with the basaloid morphology in like adamantinoma like Ewing sarcoma. However, it is CD99 negative mostly, and this NUT1 immunostain is very useful for confirmation. Basaloid squamous cell carcinoma shows similarly P40 positivity. However, they will be more shows more atypia, and they are CD99 negative. High-grade neuroendocrine carcinoma also shows rosettes and peripheral palisading and synaptophysin positivity, but lacks diffuse P40 and CD99 staining. Olfactory neuroblastoma also again mimic adamantinoma like Ewing sarcoma, but it lacks cytokeratin or CD99 expression, and it shows diffuse synaptophysin positivity. SMART-B1 negativity shows loss of SMART-B1 expression. However, in our tumor, as we saw, INI was retained. And this tumor usually shows a plasmacytoid or rhabdoid morphology. Sinonasal undifferentiated carcinoma usually lacks this diffuse P40 and CD99 positivity and shows marked nuclear pleomorphism. So the take-home message is poorly differentiated tumors with basaloid growth can be challenging and requires demonstration of lineage-specific differentiation. Expression of synaptophysin with absent or focal chromogranin and P40 immunostaining should raise suspicion for an uncommon tumor like adamantinoma like Ewing sarcoma. And useful markers include CD99, FLI1, and NKS 2.2. Epithelial markers including cytokeratin, P40, and CK5R6. Molecular testing for EWSR1 FLIG fusion confirms the diagnosis. So in our case, we could not confirm the diagnosis by this molecular testing. However, IHC was favoring this diagnosis, and we presented it because it's a rare kind of a tumor which is not commonly seen, and it has been recently only described. Thank you.
Thank you.
KCIAPM for giving us the opportunity to conduct this KCIAPM slide seminar for the month of October 2025. When bidding came for which month, we discussed with our previous HOD, Dr. Jayaprakash Shetty. We settled that it is October is the best month. Even last year also we conducted. Thank you for interesting this KCIAPM, interesting KSHEMA for hosting this KCIAPM workshop. I would like to specifically thank all the postgraduate from a different institution. I think many of you have done wonderful job, and it was very close DD in fact. And so thank you for this giving us this a beautiful differential diagnosis, or some you exactly hit the diagnosis. Thank you and your department head and department or your colleagues also help in conducting this. Special thanks to all my postgraduates or there is a faculties those who are presented, those who took time for preparing this case. When we sat together, which all the cases, there was a wide variety of cases we had, but we settled. There are many, plenty of cases, but we settled. There will be some learning point from each case. We settled at so these 12 cases of spotter and discussions like. Thank you. I would like to thank all the participants those who attended, and we found in between it has gone up to 120 now. I know it is around nearing 5. The total participant now it is gradually it's going down, but it was a good participation from you. In fact, many of you observed the slides, and it was a very good differential diagnosis you have given. Thank you all for attending this KCIAPM slides webinar. Thank you, Sri Lekha. Thank you. Over to you.
Thank you everybody for attending. Have a good day.